So I know there's been a whole lot of information that you have had over the past day and a half, and it's difficult to sort of process everything, I guess. But just to kind of reorient ourselves as a group, this is the fourth theme that we had as part of the different sort of broad topic areas that we wanted to cover over the next these 3 days of the first GIN forum. This one is specifically looking at actions to reduce health risks associated with extreme heat. I sort of use the word action and intervention somewhat interchangeably. Intervention, I think, is a very public health, specific word, whereas actions are probably something that a wider audience might be more familiar with. But those terms are sort of used interchangeably in this context. For the next couple of hours or 3 hours or so, we want to cover three broad topics. One is, what are people doing? What are these actions? What are these interventions that has happened both within the health sector as well as outside the health sector with health relevance? And what can we do with that information? So we would have a series of presentations. We have 6 presentations in total, talking about various dimensions of, heat health action. If you remember this slide from yesterday, and this is just one way of categorizing it, there are many other ways that we can talk about that might be useful typologies, useful categorizations of heat actions, heat interventions. We'll have presentations which covers every topic, in here. And then we would have some discussions. We would break for coffee. And after we come back from the coffee break, there's going to be, just about a 45-50-minute session where we are talking about evaluations of these actions, evaluations of interventions, specifically asking these questions: do we know what works? Do we know how well it works? And then, importantly, can we say something about how much does it take to have those interventions? What are the costs involved in implementing those interventions? And then we would want to end, again, a 45-minute block of time, specifically talking about how do you design and implement heat action plans. Generally, heat action plans here are being sort of thought about as not just a collection of heat interventions, but something beyond that, which requires many agencies to work together in synchrony, in an integrated way, and have some discussions around how does one design and implement those heat action plans. So that's just to, give us some structure in terms of, how we want to proceed over the next 3 hours or so. We would have a series of presentations. And so, again, if you remember that pyramid, the sequence of presentations would essentially sort of follow that pyramid structure that we had, starting from really individual household level interventions and then sort of, scale up. So we'll start with Dr. Kaz Ito from the New York City Department of Health. And also to mention, we are just one presenter short in this. We were supposed to have 7 presentations, but now we have 6. So we won't be, that strict about time. So you can sort of give your remarks. 8. 10. 10. 10.
Thank you for inviting me for this session. Actually, I should mention I was attending this morning's session, and Oli J from Australia was talking about how the electric fan may actually be effective in humid environment, which would kind of change my perspectives. Because New York City Department of Health, we've been pushing for air conditioner, as you will see. But if the electric fan works, then that can change quite a bit of things. Maybe I should revise my slides as we go along. Just to give you the perspectives of how the New York City temperature changes. So New York City has a population of 8.6 compared to Hong Kong 7.4. Economic disparity in New York City is very high. It's like a second highest in United States, with Gini coefficient of 0.54. Much of this economic disparity is correlated with racial compositions, and that's the whereas Hong Kong, I think ethnically you have something like 93% Chinese, whereas, but also Hong Kong has also high economic disparity. Gini coefficient is something very similar to New York City, it's probably lower. But in case of New York City, we have in a recent census, 33% white, 26% African Americans, 26% Hispanics, and 13% Asians. And economic disparity is very related to the racial mix. Now, in terms of air conditioning, we have we conduct surveys every 3 years or so, and the most recent one in 2017, the citywide air conditioning rate is about 90%. But some of the more economically disadvantaged neighborhoods, we have 75 to 80%. I don't know the air conditioning rate in Hong Kong, but I'm guessing just looking at the apartments, probably you have like 90% air conditioning rate. In terms of temperature fluctuations, New York City has sort of extremes. For reference, I showed Hong Kong temperature daily maximum, and this is New York for 2017. So the Hong Kong temperature stays high, but New York City has very cold and very hot. You can see these are the heat waves. In a matter of a few days, we have like 10, 15 degrees positive spikes. So that's the sort of difference in terms of characteristics of heat. And based on our studies, we estimate on average each summer we have about 450 heat-related emergency department visits, 150 more severe hospitalizations, and 13 heat stroke deaths. Now, so these are the external cause of death, hypothermia, heat stroke. But when you model, when we apply time series analysis, we estimate on average about 115 excess natural cause deaths. So that's basically about nearly 10 times more than heat stroke deaths. So some of the things that we did in New York City, we conducted the first, so we have heat advisories, but the heat advisory trigger threshold temperature is not based on epidemiological studies. So around 2005, 2006, we conducted retrospective time series analysis looking at the relationship between maximum heat index and mortality. And this is analysis of May through September. And you can see that it has nonlinear relationship. And prior to this analysis, the heat advisory trigger was here. But after this analysis, we basically approached the city's emergency management and local National Weather Service, and suggesting that heat advisory threshold to be lowered to this. I'm sorry, this is expressed in Fahrenheit, but it corresponds to this was about 41 degrees C, and this is about 36. So we lower that threshold. And in terms of the characteristics of heat stroke death, after 2006 heat wave, we developed a protocol to collect information associated with the heat stroke death, including surrounding situation like absence of air conditioning. And the study found that most of the heat stroke deaths occurred at home with no working air conditioner. Study by Columbia University going back in time observed that natural cause excess deaths impacts have been declining over the years. Our study, unpublished also, is consistent with this, and we suspect that is related to the increasing air conditioning prevalence. But the problem is with air conditioning is that even if you have one, people don't necessarily use them. So when we conducted the survey, significant fraction of people who do have air conditioning didn't use them on hot days because they either didn't like air conditioning or not feeling hot to turn it on, or that they had concerns about the cost of air conditioning. In terms of the individual and neighborhood characteristics, we conducted case-only analysis in collaboration with Columbia University. Jamie Madrigano led this analysis. And on heat wave, extreme heat event days, and a few days following, we found that people who live in high poverty area, people who live in high percent African American area, also that was not just a neighborhood, but also individual level was associated with high excess deaths during the heat wave days. And other factors that were associated included lack of green space and high surface temperature. So based on this, we developed a heat vulnerability index. Another interesting study, the recent study conducted by this was New York City College, they did indoor temperature measurements, and they found that apartment rooms without air conditioning, indoor temperature can remain high, and it can be 10 degrees higher, but they remain high days after heat waves because of the thermal inertia of buildings. So based on these findings, we suggested what we can do about this. So we disseminated this information in our agency's portal that residents can look at. And so this is the map of heat vulnerability index. It's essentially the linear combination of a standardized variable of these risk factors: percent poverty, percent African American, actually this is lack of green space, and surface temperature. In this analysis, we didn't include air conditioning because air conditioning data are not available on a household level. But the city also conducts the survey to estimate the neighborhood level air conditioning rate. And this is from 2014 survey. And you can see that the neighborhood that has high excess deaths due to these factors are also the neighborhoods with high lack of air conditioning rate. So based on all these studies, so our position is that to push air conditioning to mitigate the heat impacts. And of course, saying this is challenged by all kinds of concerns, including the higher energy consumption, increasing air pollution. Air conditioning also increased the neighborhood level temperature. But so when your citywide air conditioning rate is 90%, and even knowing that people are dying indoors with air conditioning, we have no choice but to push for this, the air conditioning. It's just that the challenge is that some public housing don't have a capacity. They have to do retrofitting to accommodate that level of air conditioning. Also, a survey found that some people may not use air conditioning, so we have to reach out to these populations to encourage air conditioning use. And the other issue is that economic problem. So not only we need to provide air conditioning, but we have to pay for them. And there are challenges in doing this. Currently, what we are doing is how can we use national insurance for elderly or the poor to buy air conditioning and possibly support them. Now, let me mention other things what we're doing. So once the temperature hits that threshold, actually forecast temperature hits that threshold, the Office of Emergency Management convenes the heat action, and every day, and actually the days before the forecast heat wave, more than 20 agencies we have 11 o'clock conference calls for situational awareness. And what health department does is that we have, using the syndromic data for heat-related illness, ED visits, and emergency management, emergency medical calls for heat-related illness, we have regression model on a daily basis. We estimate, or we predict the estimated, predict the number of heat-related ED visits and compare them with what we observe. And if they are consistent, our messaging sort of stays the same. We observed increased heat illness ED visits, and so we have to keep alert. But when it's much higher than what's predicted, then we have to ramp up the message, that kind of thing. It's a very stressful situation because the data comes in at 9:30, and we have to be on that call at 11, and we have to prepare this narrative. And about 5 of us responsible for this task every summer, and it's not fun because just the fact that model can predict heat-related ED visits as we expected means that we are not doing enough, right? So anyway, based on that map, mayor's office is also planting more trees to cool the neighborhood level temperature. And also we have 2 pilot projects called the Be a Body. So this is reaching out to the vulnerable population, but government cannot knock on the people's door because historically we don't have that trust. So what we do is we fund the community organizations and ask them to reach out to these populations. And so AC use is problematic in terms of energy, so we also conduct a health impact assessment for different scenarios. We do this for air pollution, but we are about to do this for air conditioning. That's about it. Thank you.
So you could have questions for the speakers later on when we are having the discussions. Dave Hondula from Arizona State University.
Good afternoon, everyone, and thank you to the organizers and hosts for what has been a terrific meeting thus far. Again, my name is Dave Hondula. I'm from Arizona State University in the southwest of the United States, and a pleasure to be with you to share a little bit of our experience in the Southwest through cooling centers as an intervention, which exists both in my home county of Maricopa County, where the Phoenix metropolitan area is located, as well as some other places in our state. I would like to note that I'm not necessarily here as an advocate for cooling centers as an intervention. In fact, we might think that the simple fact that we have cooling centers suggests that we have some weaknesses or gaps in other social systems that cooling centers are filling as a bit of an emergency or Band-Aid measure. I'm not necessarily opposed to them either, but I think a point for discussion. As a brief introduction to our geographic context, the Phoenix metropolitan area is located in the same climate region as Death Valley, where the hottest temperature was ever recorded by humans on Earth. We experience heat as a chronic rather than an episodic hazard in the summer months, which informs how we approach our intervention strategies. We do, of course, have periods of abnormal heat even by our standards, and the interventions I'll be talking about were largely formalized in response to a particularly severe episode that occurred in 2005. I suspect that there have been significant heat events prior to 2005 in the history of Phoenix, but this was one of the first that captured significant media attention. If your eyes are not as sharp, you might see, or might not see, that this is from the National Public Radio in the United States. This was a national news story that homeless people were dying on the streets in Phoenix during this particularly hot event, which compelled action. And one of the actions that it compelled was the formalization of what is known as the Heat Relief Relief Network. This was an effort undertaken by our Regional Planning Association, which is known as the Maricopa Association of Governments. So not a local health department, not a city government, but this regional planning body played this organizing role in formalizing the network. The city of Phoenix, the city proper, was also involved in the organization as well. And although there had been places in Maricopa County that had been operating as cooling centers prior to 2005, this brought them all together under an umbrella of sorts and created a little bit of consistency in terms of communication and what it meant to participate. And as I'll talk more about in a few moments, I think what's particularly interesting and distinctive about the network here is that this is almost completely voluntary. Businesses, community centers, different types of organizations opt in to participate as a part of the Heat Relief Network, which has some advantages and some disadvantages. In 2014, the Maricopa County Department of Public Health, along with the State Health Department and Arizona State University, undertook an evaluation project of the cooling center network. Maricopa County, I might argue, along with New York City and some other entities, has been among the national leaders in heat surveillance and other heat-related health activities since the earlier mid-2000s, and has been increasingly interested in understanding more parts of the heat system. And I remember very clearly the conversation with the senior epidemiologist in 2013 who said something like, you know, we are always recommending that people go to cooling centers in our county, but we don't really understand what happens there. And that was true throughout the organization. So there was very little understanding of what cooling centers were, how they operated, what they looked like, and most importantly, was anybody using them or were they helpful in addressing the heat challenge? So we designed and undertook a arguably somewhat rigorous evaluation project where we deployed teams to visit each of the, at the time, 4 to 5 dozen cooling centers in the region. We had surveys that were left for visitors of the cooling centers, which was only a partially successful strategy. At some of the cooling centers, the response rate was much higher than others. But the parts of the evaluation that I think went much better were that we had a systematic observation of what type of resources existed at each facility. So we were counting chairs, we were seeing how many people were there, what they were doing, what resources were available, and then what I thought was the richest part of this evaluation was half-hour to hour-long interviews with a person who identified themselves as the manager of these particular facilities. And of course, we don't have time to review all of the results from the evaluation today, but I invite you to either visit the Maricopa County Department of Public Health website, or you can read the paper here in Weather, Climate, and Society, which has a few of the highlights. Just as a couple notes from the evaluation, we did find that the cooling centers were used, which we thought was a really important piece of evidence. On an average day, we estimate that somewhere between 1,500 and 2,000 people visit a cooling center. Now, are they all visiting them to seek relief from the heat in an emergency sort of way that we might be imagining here? Not necessarily. Some of them are visiting cooling centers for a meal or for socialization or to play bingo with their neighbors in a place that is also operating as a cooling center. It's a little difficult to tease out the specific contribution to heat at these facilities. Also, an interesting number, we estimated that about 2,500 water bottles are distributed through the Heat Relief Network each day. That's 250,000 water bottles over a 100-day-long warm season. So we're thinking about trade-offs and how we're spending resources and sustainability more generally. That's a lot of use of plastic water bottles through the Heat Relief Network, which are probably helping keep people out of the hospital and maybe even alive, but it is a lot of resources there. When we're thinking about costs as well, which I know is an important part of our theme here, most of these facilities identified little to no additional costs to participate in the Heat Relief Network, which perhaps is good news, that it's easy for facilities to opt in, to participate. They're not seeing this as much of a burden. Many of them saw operating as a heat relief site as part of their mission. They said, well, we'd be doing something like this anyway. Participating in the Heat Relief Network is a natural extension of what we do as an organization. But if we're not spending many resources on the cooling center network, does that mean that it's not as optimized as it could be? If this is a voluntary ad hoc model, I wonder how that constrains what we might be able to do. A couple of other notes. my training is in atmospheric science, so we measured the temperature in the cooling centers, and we found that they were cooler than the outside conditions. That was encouraging. And we did find some opportunities for improvement. We noticed that the signage was not particularly good. Even ourselves, as the, quote, experts on the heat relief network, had a tough time finding how to enter some of the facilities. We were driving there in our car. We weren't heat exhausted. We weren't tired from sleeping on the street the night before. So we thought that was a really important opportunity for improvement. And what has happened since the evaluation? We have had some success in sending the message or sharing the message with our partners in the city of Phoenix. As some of you may have seen in the national media in the United States anyway, Phoenix is trying to take a more systems and evidence-based approach to its management of heat through what it's calling its Heat Ready program. And one of the pieces of evidence that they have used is our data from the evaluation, knowing that people find out about the cooling center network through word of mouth, as well as that signage was not particularly good. So the key picture here is this woman in the green shirt on the bottom right. She's a volunteer through the Community Emergency Response Team, the CERT program that exists in Phoenix and many other cities across the United States. And CERT volunteers don't have much to do in Phoenix in the summer months because we don't have many disasters to deal with. We don't have tornadoes, we don't have earthquakes, we don't have hurricanes. This makes it tough to retain volunteers in the system, and they don't stay as sharp or up to speed on how to respond. So for the first time this summer, CERT volunteers were activated and deployed to spread the word about where cooling centers were in Maricopa County. And we're still measuring some of the data that came as part of that outreach effort. And then we've seen other jurisdictions in Arizona become interested in evaluation. Yuma County, which is located in the southwest part of the state, which is even hotter than Phoenix, has also recently undertaken a cooling center evaluation. And interestingly, they started from a different direction. They first surveyed the user base for cooling centers. They and our team from the university was out on the streets looking for people, primarily homeless population, to find out if they knew about cooling centers, how they were using cooling centers, and so on, and we're still crunching the data there. Just a few takeaways from our experience. I think we found that cooling centers are used by many in Maricopa County and in Yuma County as well. The cooling centers offer a variety of services. They come in a variety of forms, perform a variety of functions. There's little or no cost to operate under this voluntary model. They are probably helpful in reducing exposure based on what we know about people's day-to-day experiences who are using the network. But the specific benefits to health in terms of illnesses or lives saved is not something we're able to pinpoint just yet, and I'd be really interested to think with all of you about how we might be able to do so. Our evaluations have produced recommendations for system tweaks and enhancements, and we're curious to think about ways that we might be able to improve the system moving forward. Thanks very much.
Next speaker would be Dr. Yasushi Honda from University of Tsukuba, please.
Okay, I'm Yasushi Honda from University of Tsukuba, Japan. Actually, I would like to acknowledge that this study was mainly done by my colleagues at Nagasaki University, and I just asked them to conduct this study. So then let me go further. The motivation of this study is that heat warning systems usually set a threshold, and there's an inherent problem with that. There's a false positives and false negatives. Whatever threshold you take, you can't get rid of that problem. And the other problem is that vulnerable people, usually elderly, actually children are taken care of by their parents, and the problem would be less. So in any case, the message should be very simple. These are the my concern, and from that concern, I sort of reached the conclusion that we should use the room temperature for cooling decision, not the the forecast, because there's a distribution, and even when the forecast is above the threshold level, some of the houses are cooler than that, and they don't have to do something kind of things. And the other thing is drink a glass of water between the meals, regardless of the temperature. By doing that, people can make it a custom, daily work. I mean, daily things to do. They don't have to think about temperature. They can just drink between the meals, and this is very important. This much drinking water doesn't harm at all for ordinary people. So these two messages can be applicable to the vulnerable elderly. That is our target. Of course, there are people who need strict restriction of water intake, like people with heart disease or respiratory disease, but they are taken care of by the medical staff, and so we can leave them for the medical staff. Other than that, we need to do something for vulnerable elderly, and the majority of people, they can get information from the mass media, and they can they can act correctly through that information. So we can leave them alone. So we are concerned about this vulnerable elderly. We need to make them behave better. So what we did was community intervention. In an island, there was 5 communities within a city. So we divided it into 3 groups. The one, heat health warning plus water supply. We physically send them the bottles of water, and with a message that you should drink between the meals and look at the temperature to decide whether or not you switch on the air conditioners. And the second group is only the heat health warning. Actually, this community has a sort of communication system between the city center and each household, and they can issue heat health warning directly to the houses. So the second group has that system, and the third one is the control. And if you are interested, this is the paper we published, so you can refer to that. And the results is that behavior change occurred in the heat health warning plus water supply group. They became aware of the problems, and they have higher frequency of change in nighttime aircon use and more water intake. So this shows that by sending that kind of message, you can change people's behavior, and that's very important. Okay, that's it. Thank you.
Thanks, Dr. Honda. Jerome. So next speaker would be Jerome Fawcett from the Vietnam Red Cross. German Red Cross, sorry. You are in
Hello, good afternoon. I'm Jerome Fawcett from the German Red Cross in Vietnam. So I'm going to present about our project in Hanoi. So when we started the project, we knew that in case of heat wave, we have an increase of hospitalization for, especially for people with respiratory disease and for people with mental disorder. Oh, yes. Sorry. Here we go. So it's different from mine. Sorry. Yes. So we wanted to use a new approach for forecast-based, which is called forecast-based financing for dealing with heat wave. As you know, the Red Cross movement is very much famous for responding to disaster, man-made and natural disaster. Generally, we act after the disaster occurs. But for the last 5 years, the Red Cross movement, with the support of the Climate Center, we have piloted a new approach called forecast-based financing. The forecast-based financing aims at anticipating the disaster and acting before the disaster occurs, which is basically to act on the forecast in the window of opportunity between the forecast and the occurrence of the disaster itself. So this methodology has been piloted in 22 countries around the world, mainly for cyclone, flood, cold front, snow, but we are the first one to try it out on heat wave. So in forecast-based financing, there is 3 key components. The first one is a trigger, which is a specific forecast for a specific danger level. We don't want to forecast just a normal heat wave. We aim to forecast the one who may have potential impact. So generally, it should be something like a 5 years return period for a specific event. The second component is the early action, which is the action you do between the forecast and the occurrence of the disaster. And the last one is the funding mechanism. Very often, us people in the humanitarian world, we are lacking of money to act. And here we have designed a methodology for which, when the trigger is switched, automatically money will come in to implement the early action. These 3 components are described in early action protocol. We say exactly what to do, when to do, who do it, how much it costs, and when the money should be released. So I'm going to pilot through the 7 steps of this approach applied to our project in Hanoi. So the first step is the risk assessment. So IMEN, our colleague from IMEN, which is the Institute of Hydrology and Meteorology and Climate Change in Vietnam, has conducted a study on the heat wave, and we can see there's a number of hot days, as well as the temperature and the duration of heat wave have increased the last 20 years and is projected to increase further. With the Vietnam Red Cross Society, we have done a study on vulnerability, capacity, and exposure with 1,000 outdoor workers, which are slum dwellers, street vendors, elderlies, and builders. And we found out that most of them have symptoms of heat stroke, of heat exhaustion. About 55 to 78% of them have those symptoms, but they don't know the symptom of heat stroke. So they suffer some of symptoms of heat exhaustion, but they don't know the symptom of heat stroke. We have seen as well that about 25% of them go to see a doctor, and actually their expenses for healthcare equal to 1.5 to 2.5 day of income. And they are very poor people, so it's a kind of big issue for them. Especially because most of them will see their income reduced during heat wave. They don't have clients in the street, so they will lose between 25 to 50% of their income. What is very interesting as well, also they have symptoms. 76% of them cannot recognize the sign of heat-related illness. And only 7% of them stay in air-conditioned place as a strategy to adapt to heat wave, which is not surprising because they are the poorest of the poor, and most of them don't have a place for shade and with air conditioning. The second step and the third step are identification of forecast and definition of impact level. So with the help of IMEN, we have identified 4 potential lead time to work with, one at 3 months, one at 1 month, which are based on probabilistic forecast, mainly about temperature anomalies, and a lead time at 7 to 10 days, and one at 3 days, which are deterministic forecasts, specifically maximum temperature, but as well heat index. Now we are in the process of defining the danger level, which is quite tricky because we are lacking of, like everyone else, we are lacking of data from the Ministry of Health to really see when it's really having an impact. So we have a bit of an issue here. If we don't manage to get data, we think about working at the 95% percentile as a good proxy for triggering. The next step is about the selection of early action. So first thing we have to do is to really identify the people we want to work with. So very likely we will work with street vendors, slum dwellers, and elderly, but we need to find out where they live. So what we do is we go through mapping process. We have 3 layers in our mapping methodology. The first one is vulnerability. So here we look at percentage of poor, near poor, elderly per ward. The second layer is exposure. As a good proxy, we want to use the percentage of population living in slum, because of course they don't have access to fair conditioning. Only about 15% of them have access to it, and they live in poor housing. And the third layer is hazard. In our case, it's a kind of East Island mapping. So we compiled these 3 layers, and we are going to find out where exactly to work with it within Hanoi. So we are in this process right now, and we are using a free software which is called QGIS. It's accessible to everyone, and it's kind of easy. And we aim to share more about this methodology in the coming months. Once we have targeted the beneficiary, then we go to what we call a theory of change. Basically, we want to look at the knowledge, attitude, and practice which need to be enhanced on the left hand. We need to have in mind the lead time we have to act, 3 months, 1 month, 10 days, 3 days. And we look at, of course, where are living the beneficiary to try to design well-adapted early action. So we anticipate that we will have 2 kinds of early actions. The first one will be no-regret early action for long lead time, for the 3 months and 1 month lead time. So we think about awareness, sharing informations. What we call no-regret actions, they are the actions that you can implement and which are still meaningful even if the extreme event doesn't happen. Then as we will be closer from the potential heat wave for short lead time at 7 and 3 days, we are going to implement more specific early action. In our case, we think again about cool shelter, a bit like our colleague in America, air conditioning unit, but as well potentially as distributing cash, because these poor people are losing quite a lot of money during heat wave, and access to cash is as well access to water, and potentially access to air conditioning. So those early actions are described in the early action protocol, where we have to describe exactly what are the lead time, what are the trigger, to who we will work with, what we will do with them, how much does it cost. And as well in the early action protocol, we have to go quite deep into the how to monitor it, because we aim at being efficient and effective, and it's really part of the early action protocol. It has to be validated at national level, first because we want to be sure that we don't act in parallel to the government, and second, it will be as well validated in Geneva, where the funding mechanism is set up. So in Geneva, there is a committee of experts, science experts, but as well humanitarian people, who will assess this protocol for validation. Once validated, we go to the last step, the final one, which is about monitoring the forecast. So then we will wait until eventually we will reach the danger level. If we do so, money will be automatically released and the action implemented, which is the case on the top. If it's not released, we will carry on with the monitoring. Basically, the time duration of the early action plan is 5 years. After 5 years, we are supposed to revise it, to adapt it. I think it's very relevant in the changing climate, and as well for improvement. So the project basically starts in June. It will finish in December 2020. So we have a lot of work to do before the end. But if you want to know more about forecast-based financing, I invite you to look at the first website. The second website is about more a project in Hanoi. We have developed a newsletter. So we try to publish regularly, maybe each single 2 weeks. And I would like to conclude by these two pictures. On the left side, you have traditional adaptation to heat wave that you can see in rural setting. And on the right side, you have the kind of mirror of it in Hanoi, in urban context. So it's quite nice to see how people are adapting in urban context. Thank you very much.
The next speaker will be Lars Niebuhr from University of Copenhagen.
Thank you very much. We were only given 4 slides and I actually included 7, so I spared my name on the introduction slide, but as introduced, I'm Lars Nybo. I'm presenting the Heat Shield project, which is an EU-funded project primarily focusing on European workers, but I believe that the knowledge I'm going to share with you here today is also of universal importance. Just in some regions, you experience more heat, therefore worse conditions than we do. I introduced this slide here not to get in a position with all of you focusing on preventing death, but urging that we don't only see that as, because I think that's only the top of the iceberg of the problem here, at least in numbers. I mean, depending on how you calculate it, and this is where our focus is, you have around 2 billion working people or people exposed to heat during some part of their working life. So this is a major problem. And why is this of important for health? It is because when you're exposed to heat, it impacts your productivity. And we all know the very strong correlation that there are between prevention of poverty and health. So that is why we have focused on this in a health perspective. You can also say in the countries who are much affected, the development of good healthcare systems may be offset if it limits the national growth in economy. So that is one of the ways why we are focusing on this. This is actually also just to set the scene. Andreas already presented this, the way we have developed a method of using time motion based analysis to evaluate how much time do you actually lose when it's hot. But this is not just for European workers, whether we do it on Indian workers, and we actually calculate output, not only how much time you lose, but crop output. Then we can see that as the temperature increases, or whether we just use air temperature or any index, then you lose some productivity. On average, we see that on the hottest day, when it's from 30 and above, in agriculture, in construction, outdoor industries, these numbers can be around 15%. And you can say, if you're paid by piece as a worker, then you can say, should I work that longer? Should I work on the Saturday as well? Or should I acknowledge that I then lose that of my income? So then you can say, okay, we know that, and we can argue the steepness of the curve and all that, but I think that's academic. What we need to look at is, what about interventions? Can we do anything? Because these numbers here are when we just observe people doing whatever they do, business as regular. So you can say, okay, what if we then do actions? One of the things that we have tested and in this is, what if we provide breaks, small breaks, frequently applied over the day? What appears was that then you actually lose less time on these irregular breaks, but if you then add up the time that you give the worker, then it equals out. Then you can say, oh, that was disappointing. That's not an option as an action that can improve productivity. On the other hand, it's free to give it. So you can produce this knowledge and you can go to the employees and say, well, look, if you do this, and what we then, as I will show you later, use these breaks actively to do something meaningful, then it's cost neutral. At least you don't lose more time. Then we did other interventions in this, and I will not go through them, but we had some clothing interventions with ventilated garments, and actually they can produce some relief and also increase productivity. And you can also, by lowering the metabolic load, therefore lowering the workers' metabolic heat production, because how much you affect it is not just a product of the environmental temperature, but of course also on the thermophysiology, where metabolic heat production by the worker the people themselves is a big thing. In this one, we were not successful by the clothing intervention. We have in other settings done some intervention that actually can produce a relief by changing the clothing, but since my time is sparse, I will not go through those. One of the things that came across when we did all these studies across European workers, and what was actually, I must be honest, a surprise to me, was that 70%, and we even observe in some industries that it's 80 or 90% of workers, they initiate work in a condition which is suboptimal from a hydration perspective. We measure urine-specific gravity, which is a rough estimate of hypohydration, that you're dehydrated. But it tends to create more positive falls than it produces that you are actually dehydrated. So if you just drank before, then you may have a lower hydration. So the numbers may, if anything, be worse. But what happens is that for Greek workers, whether they are police workers, agricultural workers, or in the tourism industries, they initiate work with a suboptimal hydration status. So even though some of them are capable of actually drinking enough, as you may see, some can catch up during the day. And of course, the police officers having more time in the cars may be better off than the agricultural workers, because the agricultural workers, where you have limited access to water, it just aggravates. What we did in this study was then also to contextualize what would that mean if you are at this level. This is mild hypohydration, 2%. So we actually in a controlled lab environment, and that's one of the ways that we work. We combine observations or actions, interventions in the field, also with validating the physiological effect in lab studies. And if you look at this study here, then you can see what impact this has on cognitive function, on motor function, functions that are important of workers, not only workers who do tough manual workers, but also work that counts on attention and the ability to make right decisions and respond appropriately. And the thing is, if you only heat stress, yes, it affects your performance, but if you are adding or if you're becoming dehydrated on top of this, just by these numbers here, then it has a massive effect on your performance level. Another way to prove that if you then target this was an intervention that we did with the study that Andreas led by construction workers in Spain, where we applied fixed hydration. So in this condition here, in the small breaks that they were given, we supplied them with 750 milliliters water every hour. And what we can see here is that we actually more than half, but that would be a fair estimate. By optimizing hydration, we can approximately half the loss of labor. And if you go to the employees and say, well, look at these numbers, they will buy in on the idea that it is a good idea to supply your workers with water. We also tested different intervention, and again, the plant breaks break even, so again, it is cost neutral. But if you use these breaks to secure hydration, then you can say, okay, this is some case studies that we have done. In addition to this, and this is one step, of course, to evaluate is the method, whether it is fanning, whether it is hydration, is it effective from a physiological point of view? Either that it lessens the thermophysiological stress, or that it improves or benefits productivity, which can then benefit both employees and employees. Another way is, of course, also to identify all these solutions. What is the size effect of this? And this is from a systematic review of systematic review. So we included some where there has been meta-analysis. And you can say one of the reasons why hydration is so low down here is because this is from studies where people normally start from a hydrated point. So when we see so massive effects, it's probably because the day-to-day hydration is not so effective. If you look at all the numbers down there, if you look at all the knowledge, people know they should drink not enough, but apparently they fail, and especially if they fail to rehydrate from day to day. In addition to this, what we also did is look at the sustainability from another point of view. So is it effective? Yes, some of these is. We also look at what is the cost, because if we are talking sustainability, we should not just look at it from an environmental perspective or from a health perspective, but also what is the cost of this. And we should also look at feasibility. Is it feasible to do this? And when I put 2 thumbs up here, it's because air conditioning is very feasible in some conditions. If you're a driver, truck driver, inside your cabin, you can apply it. But in many settings, not just because, as you can see, we also evaluate that for the environment, this is not so good. It has a large green footprint. But in some settings, it's not even feasible. If you're a greenhouse worker, if you're working outdoors, and in many settings, it's not applicable. So what we have done is we have evaluated all these methods from what we call the quadruple bottom line. Is it effective, costs, feasible, and the green footprint? And in that way, we can identify all these types of solutions. So when we go and propose something, we can say, okay, this is what you should do. Is it effective, and can you choose between this? What is the cost? Is it feasible or not feasible to implement? And the reason why some of these, which are quite effective in many exercise studies, is why are they not so feasible? Well, if you have to go and ask a worker every half an hour to go and pre-cool for another half an hour, well then you lose more time than these workers do anyway. So this is one of the ways that we have worked to identify these, but also to produce the number or the evaluation of all these parameters of importance for them to be implemented in a sustainable fashion. Now this is actually just my, back to my conclusion, a little elaboration of the iceberg model that I don't mean that we should forget this. As Andreas also pointed out, we know that workers exposed to occupational heat stress has an increased, and in some incidents, sneaking, latent, increased risk of injury, kidney diseases, and so on. But especially this one, it impacts productivity. That may, for some, impact poverty, especially in low-income countries. Again, we know that this will have effects on individual health. And if we as a global society want to benefit health, of course we should look at how is it that we then optimize the individual's health. Improving health for billions is targeting them as group, but also as individuals. Thank you very much.
And the last speaker in this session, Chaure.
Okay, good afternoon, everyone. So I guess you may be very surprised why a researcher from Faculty of Architecture will talk about this kind of overheating things. And now let me show you some of our local news first. Okay, so this year, Hong Kong experienced longest this kind of heat wave situations. We break out the records for over last 50 years. So this is one of the news showing that in Hong Kong, the poorest neighbors struggle to keep cool during such kind of long heat wave events. And local news articles showing that they do a survey for those subdivided house units, this kind of inside temperature. Normally, they can experience 80% of time was higher than the outside, and the indoor temperature sometimes can reach to the 42 degrees Celsius. And another interesting thing is the poor family, the mother have to shower her 6-year-old daughter 3 times per night, and the whole family have to stay outside as long as possible, so they can let the home cool down, then they can have a sleep. So from this kind of new articles, we make me rethink how we can create a livable situation for our poor neighbors. And in Hong Kong, I guess in the last few days, you already have some personal experience or impression about this kind of situation. We are located in the subtropical climate. Right now, we have very comfortable, mild winter. But if you come to Hong Kong in the summer, you will experience hot and humid summer situation. And right now, our population is about 7.3.5 million people, and urban areas only occupied 23% of total land area. And in Hong Kong, about 50% population lives in the public housing. So this is like a family photo, and you can see the outside we have a high density situation. Inside is also compact and high density, but they still have window here. And we have about 0.2 million people living in the subdivided units according to the data from the 2017. So you can see they don't have any air conditioner and they don't have a window. And we still have about 0.1 million people living in the cage. And normally this kind of cage home located in the old industry areas, they have very poor hygienic or living conditions. And also in Hong Kong, we are facing this kind of aging society, poverty issues. By 2020, about one-third population will be aging elderly people. In the meantime, one-third of elderly people will be the poor people. So we have a big issue. And also in Hong Kong, according to our latest records and data showing that our life expectancy is almost a number one, number two on Earth. So we have the longest life expectancy in Hong Kong. And so that is why our team, we work very closely with Hong Kong government since 2003, we create a series, this kind of urban climate and environment studies. And after each governmental consultancy project, we create technical guidelines and also practice note, try to cover various levels of design and planning situations. And so one of the study, we work on this kind of urban climate map. So at Hong Kong, we want to know what kind of climate situations at the city level. Is there any kind of resources and also what kind of action we can do to improve the outdoor thermal comfort situation, especially in the summer conditions. And behind these studies, we conduct a series studies, including the thermal comfort survey, and also we use a PET to understand the Hong Kong people's feelings during the summer condition. And also we conduct the wind tunnel test to examine how much urban wind situations, and also the field measurement try to capture the intra-urban variations, and also remote sensing, etc. And apart from that, we also have collaboration with Professor Emily Chan's team. So the first, on your left-hand side, you can see we get the understanding about urban climate conditions in Hong Kong. And based on this kind of map, we extract the information about urban heat island intensity. And we evaluate and put into the town planning territory planning unit, which the public health data also can get from this unit. So based on this, we can do the further heat-related impact analysis. And then we conduct further studies, try to understand in Hong Kong under the different the nighttime and daytime situations. So for these studies, we also noticed that there's a significant short-term effect of prolonged heat wave event, especially in the nighttime situation. And also, we conduct a spatial temporal analysis, try to capture the temperature distribution patterns, because we want to know how cities heating up and also cool down. And turns out, we find out even in Hong Kong, the local extreme hot weather hot night indicator is 20 degrees Celsius. Actually, our downtown areas cannot be cooled down even under the normal summer situation. So that means we can really have a lot of we can capture this kind of hotspot areas. And after our studies, we got a call from correctional institution, Hong Kong government, because they are quite worried about their prisoner. In Hong Kong, probably you think everyone will easily access this kind of air conditioning situation, but actually it's not. So for example, the prisoner, they don't have a fan or even an air conditioner in the prison. And sometimes the elderly people, because of Chinese belief, they don't like to turn on their air conditioning during the night, even a fan. So that is why we try to map out where this kind of sensitive population live and what kind of facility they have. Because later, if we want to provide advice to our government, we need to know whether the current facility is good enough or whether there's any hotspot areas to capture their attention. So we conduct this study, map out those locations, and including this kind of prison, schools, hospitals, services for elderly people, the public housing estate. And turns out we find that we check the different situations, all time situations in summer, daytime, and also nighttime. And turns out nighttime, they always have this kind of higher percentage to experience high temperature during the nighttime. So that is why later we found out the impact of built environment may cause health risk potentially. And apart from that, we work with Hong Kong Planning Department, Hong Kong government, create guidelines. Right now, if you Google the Hong Kong Planning Standard and Guidelines, you will see there's a lot of design actions, such as a breezeway, try to linkage open space, and also we have new terms, non-building areas, how to plan a better layout for the waterfront site, and also we have a control for the building dispositions and shadings and greenery, etc. And for these guidelines, we provide this kind of graphic figures so we can let the layman and general public know that what is a good design. And we also create manuals to our local government when they do the outline zoning plan, i.e. the district level renewal plan. So they can refer to this, then they focus on how to improve the thermal comfort situations and also how to bring the more wind back to our city. And so one example is in Hong Kong, one of district, which is called Kai Tak Airport in Hong Kong. After 1997, the new airport located in the Lantau Island, I believe most of you landed there. And but right now here, the old Kai Tak Airport is about 200 hectares, is empty. So and also located in the CBD area, very close to the Victoria Harbour. So the city government pay very high attention to examine the possibility how to use this area. So we work together to check the layout plan. So right now you can see the street orientations, the welcome incoming wind, and also we create a lot of green fingers, try to linkage the surrounding areas of greenery area. And also because here this is a old industry area and the surround areas is mainly old districts, old town. So we want to bring more air and the good design features to this area. And very often in Hong Kong, you can see this kind of gigantic podium and building towers. But for this district, there's no podium, so we can create more open space to the general public. And another good example is Hong Kong government headquarter office. I believe Margaret already visited this site, and she told me the greenery area is lovely. And you know why they have a gigantic hole? Because we have air ventilation studies, and also the whole site is located in the Wan Chai very sensitive coastal area, and behind this site, there is very high dense traffic volumes, and also the population density is very high. So we need to make sure the entire microclimate conditions are favorable. So that is why we suggest the architect to make the hole big enough, and also check the building positions, etc. And recently, in Hong Kong, we talk about the future long-term planning vision and also strategies beyond the 2030. So in this document, it also mentioned that Hong Kong we aim to create a healthy, comfortable, high-density city for our citizens. And in this document, it all mentioned that in future, for this kind of new town plan, old town renewal exercise, it will consider urban ventilation assessment and also microclimate, try to provide a healthy and comfortable conditions. And also another document, Hong Kong Climate Change Report, which released in 2015 by our Environmental Bureau. It also mentioned that air ventilation assessment and also urban climate mapping recommendations, greenery master plan, and also the sustainable building design guidelines. So all these documents try to put forward the livable, healthy cities for Hong Kong in future. And apart from Hong Kong, my team also worked very closely with Chinese government. In the last year, in last a few years, we create new technical guidelines and national standard on urban climate applications. And one aspect, we focus on the extreme weather and also risk management. So for this kind of extreme hot weather events and also the urban flooding issues, we also capture attention from the mainland China part. And so based on all these kind of studies, we definitely welcome cross-disciplinary collaborations because we believe this kind of planning and design, construction work eventually will tackle the health issues or problems. We need to solve this kind of people's needs. So based on our study, I think more important message here is how we can put the data science or science in time and also science in space. Because very often when we dialogue or talk to the policymakers or architect practitioners, they need this kind of spatial and temporal informations so that they can make a better judgment and design. Thanks very much. Thank you.
Thanks, everyone. First of all, thank you all to the speakers for condensing all the great work that you do within the very short time that you had to present what you do. I would, if the audience has questions regarding specific interventions, again, in the interest of time, I would request you to have one-on-one conversations with the speakers. But I want to borrow the metaphor of the iceberg and say that it's an interesting one to talk in an extreme heat session. But this was just an iceberg, just the tip of this large iceberg that the range of interventions that are happening around the world represent. And just to use your presence and your thoughts on a couple of things. One is about this need or an importance of cataloging the range of interventions happening at these various spatial scales, targeting different audiences, occupational health. There was somebody from Pakistan. He's actually a professor at Johns Hopkins University who has done some work specifically targeting healthcare providers in the city of Karachi, training them to identify heat-related illness better in order to then deal with individuals who are suffering from heat stroke. So there are different audiences, occupational health, healthcare providers, individuals, families. These interventions are happening at different scales, starting from households all the way up to city and country level. So the question was, do you as a group, as a community, feel the need for a centralized or a knowledge repository of these range of interventions? And the second one was, if so, does it make sense to sort of create typologies based on these, based on these interventions? The typologies, you could slice and dice it in so many different ways. You could create a typology based on the agencies who are implementing that. You can create a typology based on the audience that you want to address. So just to get your thoughts in terms of, question number one, do you feel that there is a need to create this knowledge repository of interventions? And question number two, if so, would you have suggestions based on your needs, typologies which would then help classify and categorize, this range of interventions? So, comments, remarks, your feedback, both from the panelists as well as the rest of the audience would be highly welcome. So.
It's on now. So I think what you're proposing will be very useful. I mean, I sit in the country office of WHO, and we get questions from the government, like what works, what doesn't work. So I'm not sure if evidence is available, but if there would be a very simple table with a list of interventions and classifying, okay, this one definitely strong evidence that it's working and it's feasible, and this one, promising, very few studies. This one, don't do it. It doesn't work. So I don't know how long it could take to arrive at that, but this would be extremely helpful as we deal with policymakers and people who make investment decisions.
Maybe I share some information here. So this year, WMO create a new guidelines, which is talk about integrate weather, climate information and services for cities. So they talk about how to make this kind of cross-disciplinary collaborations, mainly from the meteorological office, administrative office. And this is a part one, which is already endorsed by the WMO, I think around June or July this year. And right now, there's a group of people working on the part two. Part two is talk about the city's experience, basically the examples or successful stories from different cities. So right now, we are working on that. I guess probably we'll finish next year sometime. But I think you can adopt a similar, this kind of experience for this kind of studies or exercise.
In the first presentation from New York City, it was shown that the excess mortality because of heat have gone down in the recent past, and that may be perhaps because of the interventions. That brings out a question: what should be the threshold period for determining the thresholds? Could I convey it properly? No.
So you have Kaz, who would probably be the best person to answer your question.
The question, you told that the excess mortality because of high temperatures have gone down in recent years. Am I correct?
But
Okay.
It's not, I realize it's not just the New York City, the US as a whole.
Entire
The
US.
multi-city study is looking at showing the mortality impacts going down. So it's not just New York City.
So it has two connotations. Either the resilience has increased. What should be the base period from which the thresholds for warning should be designed? Taking the recent periods when the mortality impacts have gone down, or the period before the intervention started? That's the question.
So given that, I think earlier in the morning session, that somebody from Europe showing the similar reduction going down. Right. Right. So you're saying, how do you measure the impacts of intervention, given that sort of a gradual decline?
The question is that I'm based in a city. I have thresholds at 41 degrees Celsius. I trigger the heat wave warning, and 44 a warning for severe heat wave and immediate actions. What should be the period, say, from 2005 to 2010 or 2010 to 2015? I'm sorry. Say 10 to 15, the mortalities have gone down. Primarily maybe because of the interventions, or maybe resilience due to different actions has increased. So for determining those thresholds of triggering the warning, should I take the recent period or the period before we started the interventions? That was the question. If am I clear now?
If I may answer that, because I think if it is because you then have become better at warning and that has decreased, it would be stupid to go back to that. But that's also why I think, and I think it also comes back to when we're going to discuss ways to assess the effect of a given action. And I think that if you only look at casualties, then you make a mistake. You should actually also evaluate, has the message gone across? Has people started adopting the things that we suggest? And maybe you could take that as a better measure, because it's clear that if people take up your messages, then hopefully we will prevent, then we will halve the casualties or even more. So you could also say, from my iceberg model, maybe the iceberg will melt and the problem will seem to become smaller, although the heat stress is becoming better. But maybe that's because we're actually better in mitigating some of the effects. So I think that you should use the best current knowledge of what is an acceptable level. And it may also be that although the number of casualty decreases, the threshold could still be the same. So I think that it would be stupid to do that. I would go back to the idea of creating some kind of common knowledge, and also to your. I think that this should work on two lines. There should be one, looking at scientific evidence-based, where you have hardcore systematic review of literature or interventions and so on to produce a technical, or you could say a paper in WMO, WHO, RECI, or in the Global Heat Health Network. But that should go through the channels there. I think that it could be also, in this perspective, be an idea to have a collection of samples of good practices that not normally would be published, but say in Arizona we have done this, we have had these and these experiences, but still to optimize that we get not just anything goes and we can, it's just a big collection. It should actually be something that has an internal review process, so that some people within maybe our network says, okay, look at this, and then it's standardized into certain kind of strategies. What is it it's targeting? What is the, and it can be described that, and people can find it there. So I think, and I think this could feed perfectly into the ambitions that that there are to create a web platform, maybe for all climate change actions.
Because there's a lot of action happening at the local levels which don't get through, or even through the peer review process in some ways. So, is there any thought on what would be considered as acceptable? What would be considered as worthy enough to be included in this repository, even if it doesn't go through an academic type of a peer review process? Just 1 second, John. Jerome has a point.
I fully agree with what say Lars, and I think one good way to start with is maybe to involve more INGO, because INGOs and people who are working on humanitarian sector are already doing quite a lot of things on heat wave and different hazards, and it may not capture in scientific journal, but still is kind of valid. Now we have to find a way, as you say, to say the story in a proper way so it can be replicated, and it's not always done properly in the humanitarian sector, but I think there's a lot of how to do there to dig in, and I really would like to invite the organizer to look at INGO for the next meeting and to tap in their knowledge and ability. Thank you.
And we could even also, for that kind of input, produce a standard operational. We could do a standard operational procedure of how you should report your different case studies, so that we get them in at least with a kind of quality needed to be able to communicate to others. So that could be defined, I think.
John.
Yeah, thanks. Look, I'm only going to add a little bit of icing to it. There's a great example in South Australia where 2009, 2014, identical heat waves, a comparison was done. It's in the literature, so we can make connections of publications up into a repository. That's peer reviewed. It's a good example of how to do it if you want to do it with rigor. And the other one, I think, is storytelling. Really good storytelling. Because, of course, that stuff can't get into journals easily.
One solution to the question you posed about how do you judge whether information is put up or not, is it can be followed based on the existing databases, for example, for systematic reviews and meta-analysis, where if there's no information on a topic, whatever you submit goes in, and then if a second team comes after that, they have to justify what is different compared to what exists already, and then if it's just to be improved, if there's a significant improvement, it's being replaced. This is how it works for systematic reviews and meta-analysis in databases that they have when you have to register it.
Hello, I've just been given the mic, so I'm going to go for it. I'm from the START network, so a network of humanitarian organizations. I agree with Jerome's point about there's a lot to learn from INGOs. We've got anticipatory heatwave projects in place in different areas around the world. Counter-argument to this platform idea is something we've noticed is that effective activities are very context specific, and when we try to replicate or create sort of a one-size-fit-all solution, they never work. We get approached to, be a part of a new platform a lot, and we notice that, in order to keep something up to date, it's really demanding on time. I think what's needed even more is just conversations between people. I'd argue we probably don't need another platform. I think there's a lot of platforms and programs out there. What we do need to be doing is just having more conversations, and especially more conversations with people on the ground, because their contexts are, so unique.
So what do you mean when you say there are lots of platforms around?
I mean, as an agency sort of getting involved in anticipation, we get approached a lot of the time, to create an interface or a hazard map, or there's an alert platform sort of capturing all of the actions that people are doing in terms of preparedness. And we found that our humanitarians aren't actually using it. The amount of time to keep this thing updated, it's just not worth it for them. I think the real learnings and conversations are, happening sort of face to face or by Skype. Just to put a counter argument out there.
Counter argument. One of the things that I do is I'm in charge of a knowledge translation network, and one of the things that we found is that first, yes, stories are very nice and are very convincing, but they can easily be manipulated, and one needs to be quite careful about the value that are given to stories. They're useful as an adjunct once one already makes a convincing case based on evidence. So the second point that I'd want to make is that as opposed to meta-analysis of clinical trials, meta-analysis of complex populational interventions are not easy to do. They're often very different, and so trying to add 1 and 3 and 7 and whatever, one doesn't come up with an 11 at that point. One comes up with something very different, so that heat wave responses, even though the heat waves may appear to be identical, and in the context of the one locality, what was shown may not easily be generalized to another location. And I agree completely that what one needs to do is to facilitate and to encourage conversation. So I would think that if there's a platform or whatever developed, we need a way that people can contact each other, understand context, and understand the how-to, as well as what the effect of was. So I agree with you completely. And just one other point with respect to our colleague who was speaking about shifting the threshold, which is kind of an important issue. I think that there are 3 things there. One of them is revising thresholds based on new evidence, which is likely to occur as a result of new conditions. So temperature regimes and populations change, and so one always does need periodically to review thresholds. But the other thing that one can do is, even with the same threshold, one can shift the goal. So one can say that, rather than attempt to reduce attributed mortality by 50%, one wants to reduce it by 70 or 80, or also to reduce the number of hospitalizations or ambulance call-outs, or to increase labor productivity in heat wave conditions. So one can add new things to an existing threshold. The threshold may still be good for mortality, but one can add activities in order to get more benefit out of whatever we're doing. And the last thing is, one might want to try to do it more effectively or economically. So there are lots of ways that one can lower mortality in a heat wave, and maybe we can think of which ways are most effective, both directly for that and also have the most ancillary benefits. So I think there are a number of issues involved in your comment that all need to be considered.
And I think we'll get to a lot of these after your presentation, after the coffee break. So hold on to those thoughts, please. But Dave, you had a point about...
Hi, everyone. Dave again from Arizona. I like this idea about conversation, And it reminds me of a little bit of our work pilot testing this idea of a repository with Phoenix this past summer. And of course, an issue that many of the organizations face is turnover, where next year somebody is going to have to operate the intervention, whatever it might be, who might be new to that position. And perhaps we could argue about this, but it might help that person transition into their new role if there was some sort of written information about how to do the intervention. And if they're already going to be writing down how to do the intervention, it doesn't seem like it would be that much of an added cost to add it to some type of repository, maybe even with some structure. So we asked our city colleagues to write the how-to guide for how to do the intervention, then tested it with the new operators. And the first thing they said was something like, yes, this is great, but what I'd really like to know is the name of the person who did this last year and how I can get a hold of them. And that was not something that was part of the blueprint, as we called it. So how we can facilitate these connections, I think, is a really important, and in our brief pilot testing with Phoenix, would really resonate with them.
So that's an interesting point. You know, there's this unintended consequence of sort of creating institutional knowledge in some ways by creating this repository, which I wasn't thinking about. Thanks.
Well, thank you very much for the opportunity. Well, I really like the idea of generating, a platform to share evidence, because there are different countries in the world. Some countries are resource poor, so it's very good to know what has been happening in other parts, like, the interventions. As you mentioned, like, the best practices. Now, these interventions need not to be repeated, but certainly people can look at those things and design their own ones. So that's one thing. We need to have a kind of a evidence base. And in addition to that, like, we have to influence policy in some of these matters, especially in terms of occupational scenarios. For us to achieve certain things, we need to influence or, like, develop rules and regulations. So we need to sort of have evidence. And then when you increase the evidence, then of course that will facilitate, or that will, like, facilitate the policymakers or the regulators to take action. So whatever that has been done in other countries can be looked at, and if when you just, increase the knowledge base, that will facilitate these processes. And in addition to that, of course, you will be able to identify knowledge gaps. Like, for example, now are we concentrating on the school children because it's life course assessment, and these, it's not a one-time thing. So I suppose it's very good to, like, I come from Sri Lanka, developing country, so I really appreciate, and I think, some kind of a evidence-based or a platform is really necessary.
So now we have a coffee break, but if you have a burning thought that you would want to share with the group, we can definitely do that once we reconvene at 4 o'clock. 4 o'clock. Okay. Start early so we can finish early. Before we get going with the presentations, so, I just briefly wanted to come back to this idea about creating this inventory, knowledge repository, catalog, database, whatever you call it, of, heat actions, heat interventions. And since all of you are here and some of you are somewhat interested, at least not to be involved, but even to be informed about what's going on, if, we'll just pass around a sheet. Nate Nathaniel Triggs, he's going to have the sheet with him. If you could just sign your name and your email so that, we can stay in touch, let you know what we plan on doing with this, get your feedback on, and suggestions on what would be the best way to move forward. And at some point in time, you can decide whether you still want to sort of stick to that or whatever degree you want to be involved in, about that. So we'll circulate this for your name and your email. We'll continue with the presentations. This is the section where we want to have some focused discussions around, given these range of interventions, how can we evaluate these? Can there be any guidelines that we can, at the end of this session or sometime in the near future, provide to practitioners who are doing different kinds of heat interventions? And so we have Tom Kosatsky from the British Columbia Centers for Disease Control. Thank you, Tom.
Okay, so that's me, and I would sort of like to thank the organizers for bringing me here, although I feel like a university professor talking about things about which largely I know not. I'm not an economist, and it would take a good economist to make sense of this presentation. It also is not what's in your book, which I could easily talk about, namely heat watch warning systems in Canada. And if you have any questions, I'd be happy to answer them about that. But this is the issue of evaluating the cost effectiveness of heat early warning systems. Okay, so what's involved? Well, we all want to prevent something like this, or prevent the impacts of something like this. Here is a heat event in an otherwise cool, relatively cool, temperate city, Vancouver, coastal British Columbia. Never gets too hot. The idea was that if it did get hot, the chief medical health officer for Vancouver said, well, enjoy it, get out to the beach. But in 2009, there was an unparalleled heat episode, which is shown here by the red line, which is the daily temperature during that period. So during about a 7-day period, the temperature was at higher levels than had been seen previously in that city. And then the bars show daily deaths. So the dotted blue line shows the average number of deaths per day in Vancouver, which is about 44. And then the bars show the increase up to about 75 or 80 per day. And during that week, there were 130 excess deaths. There were 2 deaths that were certified as being directly due to the heat, hyperthermia deaths, and about 128 excess deaths above those expected, which occurred during that period. So this is all about preventing those deaths as well as all the other consequences of abnormally high heat. Okay, so various meteorological agencies have developed a confusing array, I would call it confusing, of watch and warnings and advisories and so on. And I think nomenclature is becoming more standard now than it was before, but these are all ways to let the public know and let makers know that there could well be untoward consequences to health of coming heat, and as a clue or a key to doing something about it. So the first thing I'll talk about is the issue of cost effectiveness. So in cost effectiveness, one looks at the most effective way to reach a specific goal. So in order to do a cost effectiveness analysis, one needs to specify a specific outcome, and then one looks at the variety of options that are available to meet that outcome, and one picks among those options that which costs the least. So an outcome may be, in this case, to reduce the death toll of an event such as happened in Vancouver in 2009 by 50%. Or one might attempt to look at the effectiveness, or the cost rather, of reducing by 1 excess death. And then one could look at various ways to do that. So, starting with effectiveness measures, here what I've done is I've uncoupled them. Rather than look at the effectiveness, or the cost, pardon me, of a reduction overall in the mortality burden, I've looked at the effectiveness of the various steps that might be involved in doing that. So, the first step would be to improve the forecasting capacity or the forecasting accuracy. And clearly there is costs associated with that. So to do a cost effectiveness analysis here, you would have to specify the degree of improvement. So you would say that in order to have a 10% increase in the accuracy of hot day warnings 2 days ahead, here are different ways to do it. And the meteorological agencies are, I'm sure, able to say that, you know, with these supercomputers or getting more staff or reorientation of existing staff, one could achieve that goal. And so that would be the first step. Then the next step in that, given that we had better forecast capacity and forecast warning capacity, would be what else is needed to reduce deaths. And the what else could be things like mobilization to limit death due to hyperthermia. As I said, in Vancouver, there were only 2 people who died of it during the heat wave, or to reduce the burden of excess death, of which there were 130, or to reduce hospitalizations, which also occurred during that episode, or to reduce consequential morbidity, so people who lived through the episode, but it affected them later by shortening their lives or by having increased burden of illness. Or one could look at the, as a certain measure of effectiveness of productivity loss, of reducing that productivity loss. Any one of those, given the above triggered action, the better forecasting capacity. And then for any one of those, one could say, well, what are different options to attain that? And options to attain, say, the limitation of hyperthermia deaths could be, first, a better weather network. Second, could be more community connectedness to reach out to people liable to die of hyperthermia during a heat event. Would be to install cooling shelters. Would be to have community mobilization efforts. Any one of those things could be specific items that could lead to any one of those goals, very specific goals. And all of those could be costed out. So you could say, what's the cheapest way to reduce hyperthermia deaths during a heat episode by 2? And then look at the various options and cost them out. That would be a cost effectiveness analysis. Okay, so what we've done is we've decoupled the various steps in order to limit the impacts of the heat wave and looked at different ways to achieve that outcome. Going back to the diagram again, seems to me, though, that decoupling is not really the way to think about it. So by having a partial cost-effectiveness analysis, what's the most cost-effective way of attaining of reaching the various steps probably isn't where it's at. Really what you want to do is ultimately to have a goal, as I was saying, to either reduce the deaths by half or by 2/3 or whatever, and you could look at various options altogether in order to do that. So, given a goal, again, you need to choose a goal, and the goal in this case might be something like cut the deaths in half in the next episode. So you could say, well, what are the different large options for doing it, and between them, internally, what are the different sub-options? So the sort of large-scale options might be to have a better early warning system, and that could include better forecasting capacity, better community mobilization, all of those things. Or it could be to develop critical infrastructure that would lead to fewer deaths. That would be things like distributing fans, assuming fans are, and I think they probably are useful, having cooling rooms, having cooling shelters, etc. Or environmental buffers could be larger scale investments, things like community greening or bluing, water capacity, increased albedo of structures. All of those things could ultimately lead to having the deaths in the next similar heat wave. So one could look at the various options or sub-options and come out with the most effective, cost-effective way of doing that. So given all of those options, one could put together a packet and say that this packet would cost $1 million to cut the number of deaths in half. Sub-option and sub-options B would cost $1 million, would cost $1,100,000, et cetera, et cetera. So the choice, clearly to a decision maker, would be to pick that series of options that was the least expensive in order to attain the particular goal. In this case, the larger goal would be to cut the number of deaths by half. And that's been described in a number of by a number of persons who've looked at the issue of costs and benefits of early warning systems for natural disasters. Rogers and Sirkanoff in 2010 described 3 specific spending items desirable for disaster prevention, and heat waves is a disaster in that sense. One is early warning systems. The second is critical infrastructure. The third is environmental buffers, and I gave examples of all 3 of those. Their next statement is that cost-benefit analysis says that an investment whose benefits exceed the cost should be undertaken, because now we're going to go to cost-benefit analysis, and if there are competing proposals, those with the highest benefit to cost should be prioritized. So earlier in my discussion, I talked about cost-effectiveness analysis. Given a particular goal, what's the most economical way of achieving it? But now we're broadening it out to cost-benefit analysis, which says that given a whole series of outcomes where we can estimate the value of the benefits, what are the costs of doing that? And his next statement is, or their next statement is, consider the overall operational cost of the system, the social and economic costs of false alarms, and the societal and economic savings due to timely action. So I'll get into that in a sec. And their last statement is consider the equity impacts, because it's not just a question of saving money or using money most effectively, but also an issue of who the money is for that should also be considered. So I've started by talking about cost-effectiveness analysis. How can one most effectively or economically attain either a specific partial outcome, a better meteorologic prediction of target temperatures, or means to get out the message to people, or means to get cooling shelters in place, etc. How can that be done most effectively? Or overall, what's the most effective way to reduce by 1, as an example, the burden of heat wave? And so that would be cost-effectiveness analysis. However, to a decision maker who's faced with doing something about heat wave-related health problems versus doing something about influenza versus building a new transport infrastructure versus whatever else they might want to do, they tend not to be interested in cost-effectiveness analysis, either partially or as a whole program. They tend to be interested in a cost-benefit analysis. So they are interested at that point in looking at the costs of an entire program versus the benefits of an entire program. And there, the program might be one that looks at lowering the burden of death, lowering the burden of hospitalization, productivity gain, intangible well-being, all of which could be given an economic value. So to do that, you have to decide what a life is worth if saved from heat-related mortality, what it would be worth saving in terms of hospitalization costs from hospitalization during a heat event, what kind of productivity gains one might want to get, what sort of intangible well-being in the population who feels better as a result of not being so hot and bothered, as well as all of the spillovers in terms of benefits to the population of being warned in advance of heat events, having fans, having a buddy system in place, all of the things that are ultimately going to prevent mortality and morbidity. So here there's a whole program. So now we're looking at an entire program, and we specify the outcomes that we're looking at, and we give a value to those outcomes. We say that the 50% fewer deaths during the heat episode are worth $3 million each. So that's $150 million worth of benefit to society. The hospitalizations, say that we want to reduce the burden of hospitalization during a heat wave from 300 to 200, and each hospitalization costs, say, $30,000. Oh, rack up another $3 million. Productivity gain. We've decided that productivity decreases by 25% during the heat episode. If we can cut that in half, then that value to society would be another $100 million. Likewise, the intangible well-being. If we gave a price to that, we could add all of those things together, including the things we hadn't suspected initially were related, like the spillover in terms of averted deaths at other times. We'd add all of that together, and we'd say that the benefit of this program, in that case, we would estimate to be the benefits in terms of the deaths averted, the benefits in terms of the hospitalization averted, the benefits in terms of productivity gain, the benefits in terms of intangible well-being, and all of the spillovers, and we get a dollar value for that. Against that, we would look at the costs. So what are the costs involved with doing that program that could ultimately produce those estimated gains? Among things we would need to do would be to have an improvement in hot weather prediction. We would want to have more connectedness between the Met Service and public health or public policy people. We would want to install cooling shelters or to identify them. We would want water distribution. We would want handouts. We would want sprays for workers to cool off during hot periods. We would want to have rest breaks as part of occupational legislation. We would want to defer utility bills for people who were at risk of having their power cut off during a hot weather period. We would want community watch efforts, a whole number of things, and we would add a cost to those, and we would compare the cost of that program to the benefits of that program. And the way that I've presented it, it's pretty clear that pretty well, no matter what program you did, the cost-benefit ratio is going to be very high. So that if you estimate that you can do all of those things in terms of benefits to the program, you can see that the costs of doing those things are relatively modest compared to the benefits that are there. Say, in my example, I think it would be something like 50 to 1. So that's a very high cost-benefit ratio. In that case, a government would say, let's go for it. We'll do all of those things because look at the savings that are going to accrue to us by setting up that program. So if you want to get a government to move, you have to go to cost-benefit analysis, and that basically is how to do it. There are lots of problems with that. There are estimates that are there are values that are attached to pain and suffering, values that are attached to premature death, etc. Lots of fudge factors are involved. But that's the sort of argument that's made by policymakers to governments in terms of making a decision, whether it's for building a road or whether it's for setting up a HARS, a heat alert and response system. It's the same sort of thinking that would go in place. So it's really a cost-benefit issue that needs to be put forward. And to do it well, again, it's not so much that you need to be a smart economist, but you need to be a very bold person putting out all of your assumptions to do it. Okay, almost done. Whoops. So, going back to those same two authors who say the costs of a warning system itself may be high relative to the benefit, and they're thinking about the cost of the Met Service. They're thinking about all of the other ancillary costs, setting up the urban greening, etc. And they say that with all of those things, it may be in certain circumstances that your cost-benefit analysis shows that it's not worthwhile compared to other government ventures to do that. And I venture to say that under what circumstances might that occur? And I go back to a place like Vancouver, Canada, where extreme heat is rare. We have not had an episode like that since 2009, and we've made a big investment. The Meteorologic Service did their own work and does better. Their predictions are getting better in any case. Likewise, the various cities that make up the government of Metropolitan Vancouver have put in place cooling shelters, have put in place buddy systems, are now ready to do something, but there's fatigue that sets in. If you don't ever call a warning,
people are not used to listening for it and are unlikely to react. It's not warning fatigue, it's warning forgetfulness. And likewise, from the point of view of the municipalities, the city governments, they've also lost the capacity over time to keep up those investments to doing things. So one could say that in a situation where extreme weather events, extreme heat events in particular, are unlikely to occur currently or in the near future, perhaps one would better invest health dollars in doing things other than a heat alert and warning system, even though under the circumstances I presented, this is so worthwhile, 50 to 1, but where in fact it's a very uncommon occurrence, it's not 50 to 1 anymore, it might be something like 2 to 1 or 1 to 1, in which case one could say, well, maybe that money is better invested in an influenza campaign. Maybe that money is better invested in school, in health literacy. Maybe that money is better invested in something else. But other than that very particular circumstance, I think it's largely a no-brainer that a cost-effective HARS, cost-effective heat alert and response system is worthwhile to implement. So that's what I had to say, and I'm open to debate some of those issues. Thank you.
Thank you so much, Tom. Just to sort of emphasize, question. Oh. Just to emphasize another point, these systems are like investments, and if you think of climate change, where you think the exposure is going to worsen, this problem is just going to get aggravated. Installing a system now not only reaps benefits this summer, next summer, but summers to come, and this reality needs to be communicated to a policymaker. These benefits that would accrue over time to an investment that you are making now suddenly could make what seems to be a very costly investment right now suddenly, have a very low cost benefit ratio or a very high benefit cost ratio when you take into account what's going to happen 5 years from now, 10 years from now, 20 years from now. So, as we think about these heat interventions, yes, some of these have different time frames. Cooling shelters, yes, it's only going to be active over one summer. If you don't do it next summer, of course, those benefits don't accrue. But if you're talking about an early warning system where government agencies are coming together and co-producing, this term came up in a morning session that I was in, and the Met Service people were talking about co-producing these systems. These would have a much larger life, and the benefits would probably be much higher 5 years from now, 10 years from now, when the problem is much worse, than what the short-term benefits would be. So that's sort of another frame of reference to have in mind when we are thinking about effectiveness as well as cost-effectiveness of some of these interventions. So thanks again, Tom. Questions around, this issue around specifically for heat warning systems, as well as the range of interventions that we have talked about over the last hour or so.
Hi, Tom. Dave Hondula from Arizona. Thanks for the good talk. I really appreciated the logic and the ideas. I think one of the challenges we've had in our work with cities is that the way these costs fall seems quite complicated. Complicated to me and complicated to them. Thinking about health costs in particular, some of the burden might fall on the patient, some falls on some insurance, some falls in the public sector in an ambiguous way. What advice do you have for us about how to package those costs and communicate which benefits might be reaped by a city versus a county versus a state versus society at large?
Okay, I think that you said it. I mean, there are, if you look at the societal issue, then you add them all up. So there's a cost to, my family who loses me to a health event, plus the costs to the insurance company that pays for the hospitalization, plus the costs to me of reduced productivity or to my employer, et cetera, et cetera. So adding them all together, it's a societal cost. The problem is, though, that cities don't pay any of those costs, so they don't benefit from the reduction that might occur in terms of the cost to society of all of those unwanted outcomes. But they have to pay to set up the system, the cooling shelters, the information system, to develop pre-event warnings, etc. I think the way to argue it is that again, in most circumstances, unless you're in coastal Canada, the costs of all of that system are really quite modest, and also there are co-benefits. So that the bigger investments, urban greening, albedo roofs, those are direct benefits to the city as well, because what they can do, unless they increase allergies, etc., to the population by an inadvertent choice of trees, they're going to ultimately lower costs to the city. So I think that one needs to look at other arguments in terms of benefits, and also to be very sanguine and clear about what some of the costs might be to them. So that even for heat alert systems, I think that given the low level of cost to government, it's not that hard to make an argument. The bigger problem is lack of awareness and lack of buy-in that needs to be encountered. But you're right that government will always say, we're not bearing those costs, so why should we bother putting up the funds in order to reduce them?
Yeah, Tom, that was fabulous. I really enjoyed it. Coming from a National Met Service myself in Australia, one of the things that crops up for us, and it's sort of interesting to understand, because I've heard about the different variety across the different parts of different countries about how they've developed their systems. In Australia, we can't afford to build different systems for different states, so we say one system will do all. And one of the good arguments that's put up is that we have a very mobile population. So if you institute one situation, one service, okay, you've grown up with experience in Vancouver, but in Toronto, if it's the same service, and your people move from Vancouver and do work in Toronto and they get an alert, they know how to respond. So it's another way of actually looking at the cost effectiveness if you have one implementation across a country. And I can think of the counter argument in America because they have so many different systems, but in some countries you can pull it off easier than others, but it's a neat way to think that it's another way of arguing when you go to the federal agency and say one system for all, and the mobility of population will be looked after.
Also, that what also needs to be considered is that mobilization efforts have to be local, so that yes, there should be, well, even the warning thresholds need to be contextualized to the local context. What's true in the Northern Territory of Australia is clearly going to be different than Tasmania. Likewise, the way that warnings get out need to be adapted to the populations, and populations tend to be different whether they're in rural or urban places, and based on the cultural communities that are there as well, so that there are differences that need to be built in, but that to have to have common warning structures is, yes, I think a very good and maybe an effective way to counter the problem.
Just a quick comment on that. So you have in mind just one intervention that's being, early warning systems broadly, and that being implemented at a city scale or a national scale or a regional scale, whatever. Part of the thinking of sort of having this discussion here was, if you put your shoes as a health decision maker and you're managing a city and you want to reduce, the burden from extreme heat, you have different options. Heat warning systems being one, cooling shelters being another, and the triggers and the process of implementing them, designing them, the agencies that are involved are very different. So could you then, how would one, given a limited amount of resource, in a health department, decide on which one do you choose, which one gives you the maximum bang for the buck? So part of the rationale to have this discussion was that as well, that can you then, use this way of thinking to choose between interventions in a certain jurisdiction as well. So.
Yes, my question is more related to timing. When I look to your graphic from the 2009 Vancouver, in the beginning of the heat wave, you had the most of the dead people. So when should you do your warning? In beginning of summer, it's maybe not a good timing because you don't know when the first heat wave will be. But the start of a heat wave, it's too late. So it's like a vaccination for the flu. If you just take it when the flu is in the country already, it's too late. So, so too early is not cost effective, too late is not cost effective neither.
First, people are most susceptible to heat early in the season, and most notice it and begin to take preventive measures early in the season. So I think it's important to get information out and to establish protective measures, cooling shelters that could be opened, water parks that could be opened, water distribution systems that could be put in place, community organizations that are ready. I think that all needs to be done early in the season. You're right, by the time of the heat wave, it's too late. There's also, though, the issue of saliency or relevancy. People will respond to a heat episode during the heat. They're unlikely to respond when it's cool. So that getting out heat warnings in Vancouver in April is not going to get very far, but getting out heat warnings when it starts to get warm are of value. And then 2 or 3 days before the predicted heat episode are of value. So it's really important to have a meteorologic service that's able to predict those events, and also to have your warning system based on prediction accuracy and on the prediction of above threshold temperatures. That's what we have in Vancouver. Our warning system itself is designed to be put in place, our ultimate warning system, 2 days before the event, based on our prediction of what's going to happen the next day and the day after during the day, the maximum temperature, and the minimum at night during the intervening night. So we have a system that allows for a 48-hour mobilization, ultimately, when the real heat event is likely to occur. Plus, we have an early season preparedness plan that goes into effect. I think both of them are necessary.
So one of the questions that I had around this issue of evaluating effectiveness of early warning systems was, the Met Service gives you a forecast which then triggers a heat warning. And those heat warnings then would trigger certain actions at various scales. Cooling shelters would open up, schools might get closed, so the kids won't be exposed to outside temperature. And so there's this series of interventions that are happening at various different scales. How would then one compare analysis, assessments of effectiveness of various interventions? Because it's a combination of factors. It's a cumulative effect that you see happening in society. It's a very ideal situation where a lot of these things are happening, but there is some limitation to what you can say in terms of how effective a certain system was. I don't even know if that is necessary to make that distinction, but I'm just bringing that up because there are multiple interventions happening at the same time.
There are two things. One of them is that there are multiple interventions and multiple outcomes. The first problem to me is how one attaches a value to the various outcomes of kids not, throwing up through heat stress, of seniors not dying in un-air-conditioned seniors' residences, of people who are living in the top floors of walk-ups not having severe health effects for now and for the future as a result of that heat episode. And then each one of those would have specific interventions that might be associated with them. And they all have costs. So one needs some data in order to assess the likely benefits of the intervention. You need to know, or you need to be able to estimate what the likely benefits for each one of those: fewer sick kids, fewer dead, and fewer infirmed seniors as a result of your measures. If you can have that sort of an assessment based on past data brought forward to current periods by a regression or other techniques, then one can make a fairly accurate or useful prediction of the value of what it is that you might want to do. In terms of the costs that you might want to do, you need to look at the direct and indirect costs both in terms of doing those things. So it's a process that, in public health, we don't tend to involve economists. So we think always that, it's a good thing governments are going to take up what we're offering. And sometimes we're stunned that instead they build roads. Instead they offer incentives to industry. I think we need to join all of the promoters with the same sort of language in order to push our ideas about population health benefits. I don't know if I've answered your question.
Yeah, just thinking about your question a little bit more, I wonder if there's an opportunity for some social science research here where we could understand who in the population is exposed to the various treatments or interventions, and then somehow or another estimate the marginal risk reduction of being exposed to those interventions. And maybe this work has even been done already. It seems like some clever sampling strategy might be able to get at this, but I'd be curious to hear other thoughts.
So I guess, thanks, Tom. Thank you so much. And so, this was sort of the second topic that we wanted to touch on as part of the discussions around actions to reduce health risks. And this takes us to the third topic, which is, development of heat action plans. As I kind of described yesterday, we've been talking about interventions sort of in isolation. These development of heat action plans have been a much larger effort where these these different interventions have been brought together, to create a whole which is greater than the sum of its parts, so to say. Multiple agencies have been involved in this. It has not only been the responsibility of health departments in jurisdictions to carry out these heat action plans, because it has affected various different agencies and various communities and sectors. And so we will have an example of how all of this has unfolded in the city of Ahmedabad in India. Dr. Dilip Mavlankar from Indian Institute of Public Health is going to talk about that experience.
First of all, thank you very much for inviting me here. It's a proud privilege to be in front of this very august and very mixed audience of high-class epidemiologists, city planners and architects and meteorologists. What I'm going to talk about is a joint work of all the people whose symbols are there. In the middle of the series is the city of Ahmedabad symbol. Right here, they are the key drivers of this whole interesting effort, and rest I will introduce at the end depending upon the time available. As I was given only 15 minutes, I have removed many slides, but before I explain this slide, let me also tell you a little bit about, let me go back and tell you about Ahmedabad. I thought I should introduce. It's almost equivalent to Hong Kong in population size, about 6 million around. When we started this work, it was 5.5 million. It's one of the rapidly growing cities on the west of India. Of course, we have all the 4 seasons, but my friend who came from Chicago in the mid-70s and spent a summer in Ahmedabad, he summarized the weather in one sentence, saying there are only 2 seasons. December is hot and May is very, very hot. So December temperatures are like maximum is 25 or something, and summers are 45, 43, 45, and I'll show you. It's dry and hot, so it is not humid and hot. The monsoon, the hot season starts in 1st of April around that time and ends by end of June. The monsoon season starts after that, and humidity increases and temperatures go down. The work started because 2010, I'm sorry, the upper part is cut. 2010, we had a heat wave which was unprecedented. I don't remember, I studied in the medical school in Ahmedabad in the 80s. I haven't seen this type of a heat wave. This is the May of 2010, 1st May to 31st May. This the black line which goes is the temperature average, maximum temperature of 2009 and 11, just 1 year before the heat wave, and it's like 40 to 42 degrees. This is the red line is the temperature of 2010. It started increasing in the middle of May, 11 to 13, goes down, and on 21st May it hits almost 47 degrees, which is almost very high. Maybe our meteorologists told us that about 100 years ago, roughly that temperatures were recorded. And it comes down within a week. This orange solid area is the average number of deaths, all cause in Ahmedabad. About 100 people die, which is like the baseline for May. It is here. The vertical bars are 2010 recorded deaths by the Registrar of Birth and Death. Somewhere here, 19th of May, this bar goes up. On the peak heat day, instead of about 100 people, 300 people died in Ahmedabad. And then it goes back, and we have estimated about 800 additional deaths in the city just in this 1 week, and total additional deaths of roughly 1,300. So that woke up the city administration when we did this analysis and showed to them. Of course, newspapers were saying many people are dying, if you look at the newspapers at that time. So that led to the city coming together and developing this heat action plan in 2013. That was the first year, and then every year we have been updating it. The plan started by first engaging with the city government. We have an elected municipal body which controls like a city council. There are official administrators, Indian civil service people and medical people who look after the health department. We did the background data analysis. We took the weather data and showed this relationship between the temperature and mortality. We also did small studies. Some students, some of our researchers in vulnerable communities, of their understanding of heat-related illnesses, what they are doing, what are the vulnerable groups, and we developed the early warning system along with the meteorology, in the sense IMD, which is the meteorology department, started developing the early warning system and looking at the thresholds. I'll show you in the next slide. We also looked at what the European and US plans were in different cities and different states, and learn from that and see what was feasible to do in the context of Ahmedabad city, and included them in our plan. We wrote up the plan, disseminated, has series of meetings with the city government, different departments, the general administrator, the chief administrator, the mayor, and started implementing from 2013. And each year after the heat season, our team of 3-4 people would monitor what is happening to mortality, taking the city data, and what is happening to the implementation side of the plan, and then revise it for the next year. There were 4 key pillars of the plan. The first is the early warning system. The meteorology department provides a 5-day early warning, starting with 1st of April till the end of June, which is the main heat season. The second is public awareness and community outreach to inform the community that heat kills. One of the issues, and I'll talk about in a minute, is people think that people are used to heat. Till we showed this analysis, there is normally in every summer newspaper reporting saying, okay, 2 people died of heat. Somebody working in the hot sun and somebody else working in some other place. So people think, oh, some people die, 1 or 2 people every summer, but they had no understanding that so many people can die. Then capacity, we also did some focus group interviews, understanding with the hospitals, and found out that when this 2010 heat emergency came, the hospitals were not really ready. And many of the teaching hospitals, summer is a vacation time, so half of the faculty are on vacation, and staff is thin in the summer time, and they were struggling, and I didn't have time, but interesting local channel videos we could procure that hospitals, the reporters went into the hospitals and showed how really hospitals were struggling to cope up with the emergency. And then reducing heat exposure and promoting adaptive behaviors and community action. These are the 4 key pillars, and I'll just show you how we developed the threshold. So we looked at, this is just a simple scatter diagram. We don't have very high-powered statisticians in our team, so we did a scatter diagram of the daily mortality with the Tmax, which is the maximum temperatures, and using the gold standard method of eyeballing the curve, we decided where this seems to be a reasonable cutoff. So one cutoff was at 41 degrees, which is a yellow alert, then 43 degrees maximum temperature, orange alert, and then 45 degrees predicted temperature as red alert. These cutoffs were a little bit changed later on. These are the later cutoffs. We had little bit earlier. I'm not going into detail, but it looks like this. This is the first intervention, early warning system. So on the left-hand side, you see every day evening, the IMD sends us 5-day, the Met Service sends the city 5-day early prediction. So what is the maximum temperature going to be, and what is the probability of that occurrence, and what is the color alert, which we have given them these cutoffs, so based on that. And the city set up nodal officer. This is an additional responsibility given to one of the deputy health officers of the city, and he has been looking after receiving this information, deciding what to do, and then alerting, depending upon the situation, the press and media, the community organizations, as well as below all the line departments of the city government. And in the heat action plan for each department at different alert levels, there are actions sort of suggested. They sometimes follow, they sometimes don't also follow, including the power utility, which is a private company. This is the second intervention, public awareness and community outreach. We had posters displayed in different places, LED displays of temperature at different places in the city, some group sort of training of key people working in various slums and poor communities. This is a training program of traffic police constables who are on the street during the heat emergency. There are some other training programs and awareness generation, and they in turn alerted and communicated that to the community. This is another set of some posters, and mobile vans were also hired sometime to do miking or announcing in the community the heat alert actions. So there are two levels of action. First, the plan starts acting for general summer awareness and preparation from 1st of April, and second level action starts about 2 days before a major heat emergency is predicted, either orange or red emergency. This is the third intervention, which is talking to the doctors, somewhat educating them, re-educating them, getting their professors to talk to them to how to manage heat emergencies, what is the recent evidence, because many of them had forgotten, it had not happened before 2010. So with series of, with the hospital staff, with the community health nurses and community health volunteers in the city, series of activities were carried out. The fourth was reducing heat exposure, promoting adaptive measures. This first picture is quite interesting. Our city parks department had this wonderful policy that the parks will be open from 5 a.m. to 11 a.m. and then they will close at 11 a.m. and then open 5 p.m. to 9 p.m. I don't understand the reason. Maybe they wanted to save staff, so we had to convince them that summer keep the parks open so that poor people can rest under the trees, because there are not many trees left in the cities. On the streets, there are not many cooling places. The other interesting thing, we have lots of religious organizations which have this big belief that giving water to the thirsty is really a religious act. So these are our city mayor who is convincing the religious organizations to set up water points, free water points, clean water to drink at about 700 to 1,000 places in the city during the summer. So which is interesting community participation, because we had a lot of discussion with whether city should do it. Finally they decided, no, we can't provide clean water. Let the community and these religious groups which already have this belief do it. So that is another interesting initiative. The third, which started in 2017, about little bit housing adaptation and cooling roofs, because one of the problems we saw is the people who live in this tin roof, it becomes like a hot oven. There's hardly any ventilation, highly dense, and it becomes very hot. So how do we cool? So we decided to try out painting these roofs with white color to reduce radiation and heating. And our mayor was the first person. He was a very hands-on mayor. So this is our mayor. He said, I will climb up the roof and paint the first roof of the city. And city decided to paint 3,000 roofs free of cost, and then promoted through advertising and others, people who could afford to paint the roofs by reflective various colors to reduce the temperature exposure. So there are several measures done. Each year we are looking at what is the impact, because we started with saying this gross mortality increase, is there any impact? So we did follow up during the years following 2013 to see whether there is an impact or not. And this is one analysis. The black line, this is relative risk of mortality with maximum temperatures of this. And this is pre-HAP, pre-heat action plan years, which is 9 to 12. And this is the curve. So relative risk almost went to 3, around 3. This is post-heat action plan years 13 to 16. It seems that at least mortality has come down, especially during very hot temperatures of 46, 47, 48 degrees. So that is one good news. We have done some further analysis with help of our team. That paper is also published. It is available. 2010 onward, the city set up a surveillance system in 5 hospitals, major city hospitals and government hospitals, to report cases which were diagnosed as heat stroke. They are all exertional or direct heat stroke cases. There were 274 and 65 deaths certified by the hospitals, which has gone down. In 2016, we had even severe heat wave than this. It has gone up a little bit, but not anywhere close to this. So the certified deaths have also seems to have gone down. We have been engaging various policy stakeholders, starting with Ahmedabad city, then the state government, then the national government, and internationally. Various policy briefs, papers, etc. were published. We also engaged, India has a body called National Disaster Management Authority. It was set up, I think, after the Bhopal gas disaster, or sometime. Orissa cyclone, maybe, yeah, not Bhopal gas disaster, but major cyclone. And there is an act called National Disaster Management. Now, the problem is, the way the act defines disasters, it has to have human casualty and property damage. Then only it is a disaster. So when we try to convince this doesn't fit into the act because there is no property damage in heat waves. But still, convincing evidence from Ahmedabad, they said, okay, we understand that they have included now, even though it is not a compensable disaster under the act, but they have taken our plan and put it on their website as a model plan. Then it started, the minister took note and they said, because what happened in one of the years, I think 2014 or 15, after Ahmedabad's second, third heat wave, similar heat waves happened in North India. And the central health minister reported saying we should learn from Ahmedabad and replicate it in other places. So now, I don't know whether you can see here. I wanted to show you the map. This is where Ahmedabad is. Now the plan is replicated in many, many cities. Of course, India has about 5,000 cities, so this is a small fraction of that, but about 30, 40 cities, and some states have their own plan. Orissa was one of the old disaster management plans, so they have a chapter in the disaster management plan on the heat action related activities. We also developed a sort of toolkit and guideline for cities to develop because we couldn't reach everywhere, so we said let's develop a toolkit which people in each city can adapt and develop. So that is the journey of our cities, development of the plan and its expansion in some cities and states in India. Now the key lessons for me are, first is involving the local city and district administration wherever this has to be sort of replicated, with the health side as well as general administration and even political side getting involved so that they understand that it is an important health and public safety issue. Then engagement with all the stakeholders, the local weather office, the national and regional weather office, using whatever the data is available. Unfortunately, in many cities in India, death registration is really not as good as Ahmedabad. Ahmedabad is way away from perfect, but at least all deaths are registered, causes are not there, but numbers are there. In many other cities, even numbers are not very well. So we have to use some measure of health outcomes. We need some facilitating, like our institute was a facilitating agency on ground. We did the analysis, talked to the people in the government and the city. So it is useful to have a university or an academic institution to facilitate the plans at the local level. And learning and adapting from the plans developed from other countries. So many countries, many places have developed plans, so we can look at it, see what is the evidence, and now this discussion is also generating possibilities of new evidence so that plans can be adapted. And after the plans are implemented, measure the process of implementation as well as morbidity and mortality decline, because sometimes we do things which may not be that effective. So we have to continuously look for measures to see what is effective. I'm not getting into cost effectiveness discussion which preceded, but at least effectiveness we have to show. With that, let me thank the organizers as well as let me now introduce all our partners. This is the city government of Ahmedabad. This is our Institute of Public Health. This is Natural Resources Defense Council, an NGO in US which has been working and supporting us. This is Mount Sinai School of Medicine. They did interesting work with our local pediatricians to show mortality of newborns and increase admissions during the heat wave. University of Washington, we have been supported through an emergency medicine specialist. CDKN has been supporting partly funding. IMD is the main service provider of the meteorology information, not only in Ahmedabad. Now they are predicting heat in about 300 or 500 cities, as well as national and regional outlooks. And this is our emergency ambulance service. We have also similar ambulance pickup data, which I didn't present, but which also mirrors the mortality data. With that, thanks again. Any comments, questions?
Thank you so much, Dr. Mavlankar. So, questions specifically around the design and the implementation and the learning, most importantly, of the heat action plan that happened in Ahmedabad for Dr. Mavlankar. Tom.
Thank you for that fascinating presentation. I'd ask, why were, presumably that heat episode occurred in places nearby as well. Why was Ahmedabad successful in all that you did versus other places which did not have the same sort of a response?
I think my understanding is unless you look at mortality data, you don't realize that so many people are dying. Because if at all this overall mortality analysis would not have been done, the reported deaths were 65. And in a city of 6 million people, 65, where 100 people are dying, 65 is almost lost. The same thing happens in because the meteorology pattern is the whole heat wave which arrives in Ahmedabad starts in somewhere in Sindh and Pakistan and then moves sort of across the desert and comes to Ahmedabad. So we have like 4, 5, 6 days of lead time. The other thing is that people are thinking that Indians are used to heat. Nobody dies of heat. Very few people, rarely people die of heat. So that is another misunderstanding. And that's where I think when we try to show, people get surprised that how many 800 people dying in 1 week and nobody noticing till you do the analysis. So. And we have done the analysis in other cities which are smaller, in Nagpur, which are similar pattern. Exactly the same pattern is seen in at least 3 cities where we have done the analysis.
Testing? Okay. I'm curious if your numbers include migrant communities as well, or just the official residents of the city?
Yes, there would be some migrants. Basically, these are people who were either buried or cremated in Ahmedabad. Now, what happens is generally if somebody, it does happen little bit inflation because somebody coming from rural area is admitted to Ahmedabad hospital, dies in the hospital there. Now, most likely people will take the body back to their own hometown and bury or cremate there. But if the family is very poor or something, or a person is not really able, they may mainly cremate in Ahmedabad. Those numbers the city doesn't separate out. They can theoretically separate out, but maybe like there is 5% migrants.
Dr. Mavlankar, one question was, it's quite evident that there have been many different agencies within the city who have been actively coordinating and participating in this process. First question was, what brought them together? And second is, what's keeping them engaged?
Yeah, the first question is easy to answer. What brought them together is the high-level political commitment. Like when we started, one is of course the data. Second is municipal commissioner, who is the general head of the city, controls all the departments. So got them on board as well as the mayor of the city. So that brought all because health department in the hierarchy of departments is somewhat lower. So if health department calls a meeting, not many people show up at the right level, they will send somebody, but lower level. So we initially got the commissioner's office or commissioner to lead the meeting. Each year we had, even though the plan was not much revised, we had the release of the plan done by the mayor and the commissioner. So that brought a level of participation from other departments. What keeps them together is now this nodal officer, which they have appointed. Fortunately, he has not been shifted because many of the government people keep on shifting. So the same nodal officer is there, so he has reasonably good connections in various departments he brings together, even though this is the 4th or 5th commissioner and the 5th mayor since we started the plan. So we have to also push it from outside to get the plan continuing, rolling every year. And we have, in some sense, been quite systematic. We start the activities in February, where it is almost end of winter. Many times we get saying, where is the summer? We said, no, we should start at least meeting now, then start the plan in April. So I think outside pushing as well as political commitment, both.
Thank you very much. This is Hans-Guido Mücke from Germany. I would like to know, your action plan is running now since 5 years, 2013. Did you ever done an evaluation of your specific measures on the city-specific measures or on the individual measures? Because we're discussing this in Europe, as I introduced you yesterday, and the UK puts a specific policy investigation research unit on this to look for specific outcome, impact evaluation, as well as the process evaluation, which means the messages you pass to the professionals as well as to the individuals. I've seen that the health impact or the impact evaluation, the curve of 2015 was lower than 2010. You explained this could be an impact of the action plan, perhaps, but did you assess this with such kind of evaluation? I would like to know.
We don't have very rigorous evaluation, in the sense we haven't done any surveys to see how many people know about the plan, but we have qualitative information. And it seems that more and more people know. There is a lot more coverage about heat plan, emergency, etc. in the newspapers. Last few years there have been social media, substantial coverage happening. So that is one understanding. But we haven't done individual component-wise analysis because we don't have that much capacity as well as data to do that. Yeah, sure. So that's why if some people are interested, we would be willing to sort of partner, and we already have some partners in doing this type of analysis.
Please talk.
The other thing is we have been discussing that is there a control city, and we have been looking, but we haven't found, because some of the cities where data is good, they are coastal and they don't have so much of mortality. Some of the central Indian city, we have identified one which was almost like a matching control, but their data has some problems, so we are stuck on that.
Now, your thresholds for warning are extremely high compared to even hot countries. In France, some of the hottest may be 36, and that is for their highest alert. I mean, your lowest. Now, as I proposed my model, that you should also remember the lower of the iceberg. And maybe you only see, because what we see is excess deaths, so you could already have something which is the 100 deaths that you have per day could be in that. But I could say that there are data from India to say that workers are affected also in the range from 35 to 40 degrees. There are data from a study by Sahu, and Vidya has some very recent results also reporting that workers. And in your network, you could also include another level of communication addressing them and giving advices to them, because workers clearly report that they are affected. And maybe if you go and ask them and say, no, we don't die, but they really can sense that they are affected in their working performance, reporting symptoms from dizziness to getting sick from the work. So that may also be one way of including and increasing your impact from the work.
Sure. I think that's very useful suggestion. We had small studies, I didn't present, of about 40 police constables on the street. We followed them throughout the summer in one summer and took their symptoms. And they were, as temperature increases, all of them are reporting more and more symptoms of heat related. Similarly, we had a study done on construction workers, about 300 construction workers. We also shows quite a few, I think if I remember correctly, 10% of the construction workers were admitted to a hospital within the one summer which we collected data. So yes, it's a very important point of workers' health.
Thanks again for the great talk. Thinking about Tom's presentation and the example he gave us of a cost-benefit analysis, he outlined very specific goals that the hypothetical city would have: reduce mortality by X percentage and reduce morbidity by X percentage. And then Hans's comment as well, thinking about evaluation against specific outcome measures, would also seem to call for those types of specific goals to be in place. And this is not intended as a criticism of any kind, but I don't think you mentioned any specific goals like that. And I think for the most part, when we see these heat action plans, we don't see specific goals. But in our thinking about it, we are thinking specifically what we'd like to achieve. So were there any specific goals in mind for mortality reduction or morbidity reduction? And if not, why is that okay, or why was that the strategy? Because that seems to be the approach that we have as a community thus far.
Yeah, sure. I think it's a good idea. We have not thought of setting up goals because we were not sure whether mortality will decline or not. So now we're seeing mortality declining. So we should think of setting up some goals. Some cost-effective analysis was done by one of our colleagues who is now doing PhD in US. It seems to be very highly cost-effective. He only took the marginal cost. So what the project added, not the total cost, which is somewhat quite different, but still it was quite a bit given that so many, and we have done in the last paper some estimate. Every year the plan seems to be reducing about 11 to 1200 deaths in the city during the summer season.
So it's a somewhat related question. Let me try if I can sort of frame it. So the burden we think is going to be very high in the developing countries, especially with the exposure and lack of infrastructure. These countries also tend to be poor in terms of the archiving, sharing, dissemination of the health data as well. Now, and then there is these, some discussions that we just had around sort of what kind of outcomes do we look at. For various interventions that we talked about, there are certain intermediate steps that need to happen, which are necessary but not sufficient to see declines in mortality and morbidity, which is sort of the end goal. Policymakers often are most convinced by looking at reductions in death and reductions in hospital admissions rather than these intermediate measures, which often are these knowledge, attitudes, perceptions. You need to change those fundamentally in order to get to that final step of reducing mortality and morbidity. So then the question to all of you is, what are your thoughts, suggestions on looking at these intermediate outcomes? And how does that get communicated effectively to policymakers to keep pushing the agenda somewhat, specifically in places where you don't have access to those health endpoints in some ways?
No, I agree that preferentially we should measure it. But I mean, I think that there's massive evidence that heat causes excessive death. There's also massive evidence that if you take actions, then you can prevent some of it. In some settings, maybe not actually for India because you had quite constant, but in other settings it's confounded. If you had a very hard winter with very deep cold spells, then you have less death during the next summer heat wave because some of those with cardiovascular diseases, they are already dead. So maybe that can, in some places, can confound it. So I think that referring to reviews referring to current state of the art, I think that we can use that argumentation. And of course, if the local politicians then don't listen to that overall massive scientific evidence, then of course we should tell them to say, okay, we are able to produce this and this kind of evidence, whether it's intermediate measures or end goal measures. But I think that it's also worth to take the entire effect in and say, this is where we can do a massive effort. And maybe that could also be an outcome of of this network meeting, to produce a very targeted political policymakers paper stating what do we actually know, what are a consensus statement from this forum that we believe, but also because we believe now we cannot keep walking around the hot potato or whatever we call it, and have a 17 or 15-year-old girl from Sweden telling the policymakers, now you start listening. We can also say that we can speak as a Cora from the scientific community, from international stakeholders such as this network, and give that message. When a 15-year-old Swede can do it in a very touching way, then I also think that we should do it.
So Hans, I think... Oh, the lady from
Well, I agree with you all that we have a lot of evidence, but still to influence the policymakers, you have to do it sometimes in local context, because we have to strengthen the surveillance and we have to show them with local data. And especially, I mean, they will ask, okay, we know that there is a problem, but how is that going to affect us? Do we have evidence, local evidence? So strengthening surveillance is one thing. And like the previous speaker said, if you can show the cost-benefit analysis, because in most of the countries, well, we don't have such studies, so that the politicians, they will understand when you show something in terms of monetary value. And then, of course, you have to, like, raise the awareness of people. People also, they have to raise their voice and say, okay, this is something we need. So all those things will sort of drive the politicians to prioritize this.
So I agree that local context is important, but in air pollution epidemiology, they do this all the time. If there's enough evidence from different countries, we assume some concentration response functions and they estimate burden, right? So if we have enough knowledge from enough cities, then we can sort of come up with local context. Using this city, which is similar to this city, we can sort of estimate, given the uncertainties, right? Because the burden of, well, rather the impacts of certain mitigations can avoid this many deaths because this city has shown this much and so on. So I think the power of the knowledge repository is that if we collect enough information, we can sort of translate and without collecting further data, push for more actions in places where we don't necessarily have the data. I understand local context is so important, but I think to some extent we can do this by gathering more information.
No, but I then also think that one of the things that this community can do is pave the road for that by saying, okay, we have this international framework, and then of course, that is of course why it's important. Likewise, the suggestion that we should have all these local conversations. Yes, but we should also have the global conversation. And the global conversation could, for example, be to address Sari Kovacs, who will have this special issue on heat warning systems and heat waves and how we can prevent it, produce a paper into that, all the epidemiologists here go together, see what are the evidence that we can put into that, and then you can use that paper as a framework for your local discussion with policymakers. And likewise, we could make a similar framework for the special issue that we have on how we can use meteorological systems into personalized warning and so on. And I think that that is some of the context that we should use this international forum for, the strength of having it internationally and then take it out locally.
This is just a question to Hans. Hans, you were formulating something that JIN, a service can JIN provide, in your comment about outcomes. If you could just elaborate on that a bit. Hans? Yeah. Because you came up with the suggestion.
Yeah, well, I would promote this idea because I think we are here listening to JIN. This is the first forum. So what is the added value for coming to Hong Kong, for me, from my perspective? I would like to get all these fantastic information I've listened to 1.5 days. So the idea is how we can provide this information to all of us. And we have to translate or transform these specific approaches into our personal or specific situation on a local or regional level, either in Europe or in the Americas or in Asia or in Australia. So I think this could be the benefit of the network, looking for specific chapters, like we discussed this on heat health action plans or heat health warning systems. As we recognize there are different warning systems available. Is there any joint activity of WMO to harmonize approaches, for example? Are there interactions between India, Pakistan, or India, Bangladesh? Are there interactions within Europe? No, there aren't. So these are many, many questions, and this could be a benefit of such an information network. This is just my idea. Perhaps I'm the only one. Perhaps there are plenty of others.
I do wonder if we're, within our own countries, leveraging our governance arrangements or aware of them sufficiently. Like under Sendai framework, which most countries have signed up to. An example in Australia is we have a national disaster reduction program, and each jurisdiction must do a national emergency response assessment, and that is contingent on funding that the government doesn't want to spend in cleaning up after disaster. They want to spend the money before the disaster. And they have promoted how much money they will save. Now that all stems from Sendai, and that's within the governance of Australia. You probably all have similar frameworks that sit under the international agreements that everyone's signed up to. Maybe a better understanding of how each of our countries are linking into the international agreements and the governance that is coming out of that, because our governments are writing those plans about how they want to change how we all work. So maybe we share some of how our responses to those international frameworks are appearing within our countries, and then individually we know who to go to. Because, for instance, in Heatwave, I stuck Heatwave into the NERAG process in my jurisdiction. They weren't necessarily going to do it. But then they all did their planning to it, and it's gone around the country now. So sometimes you need to know where to put it, what to turn on.
One quick comment, Shubhayu. When we started working with this meteorology people, we didn't understand in the sense they have developed a global framework for data collection and data sharing, whereas health people don't have anything like that. So everything is non-shareable in that sense. So I think we have to learn from them and see what is the minimum which each jurisdiction should put on their website or shareable form or something, And they have done it for 100 years. It's not in some of the Indian stations are 100-year-old data is available. So I think we have to learn and see how we can make globally accessible at least some minimum data. Mortality, hospital admissions, even though cause may not be there, all cause, etc. So where then comparisons between cities of similar type can be done.
Well, thank you again, everyone, for being patient, for listening in and sharing all the wonderful work that's happening. And hopefully we keep this momentum going. We figure out how, but let's hope we all stay engaged. And there was a signing sheet with names and emails, so that's with Joy. So we'll be in touch with you, just to keep you informed, get feedback, and then figure out a way to remain engaged in some of these things that we thought would be good things to pursue. So thanks again.